I'll introduce the second speaker. The second speaker is Thomas Rimmele from France, cytokine removal in severe burn patients. Thomas Rimmele is the chairman of the Department of Anesthesiology and Intensive Care Medicine at Edward Harriet Hospital, Lyon, France, chairman of the Department of Organ Harvest Coordination for the Hospice Civil de Lyon, co-director of the Simulation Center of Lyon University. Professor Rimmele, please.
Dear colleagues, good morning, and thank you very much for having me here. Thank you very much to Jaffron for organizing this summit on hemoadsorption. During the next 20 minutes, I'm going to talk about hemoadsorption in severe burn patients. These are my conflicts of interest. This is the outline I'm going to follow. First of all, I'm going to mention briefly like a clinical story about a burn patient. We're going to see the immunoinflammatory host response in burns. I'm going to review with you the evidence in burn patients for hemoadsorption, and then I'm going to briefly mention our project of hemoadsorption in our French burn centers. So let me tell you the story of this patient. It's a 68 years old man. He had a past medical history of high blood pressure and mild chronic kidney disease. He was admitted to the ICU because of a domestic accident, a fire in his apartment, and unfortunately he was severely burned because the total burn surface area was 50%, and he got burned on the face, on the back, on the thorax, on the upper limbs, and both hands. So at the beginning of the hospitalizations in the ICU, he was in shock, the burn shock, for about 4 days. And as usually, this patient, they received a lot of fluid, so he got 25 liters of fluid, and he got norepinephrine infusion. So you can see in red, this is when this patient was in shock over these 4 months. And then in blue, this is when he was under deep sedation. As you can see, he went 12 times to the operating room for a local treatment, the surgical treatment of the burn injuries. And of course, he got sepsis, nosocomial sepsis, at least 7 times during these 5 months. Interestingly, all the time he got sepsis, we could give him some antibiotics, and the antibiotics were adapted to the microorganism, to the bacteria. The problem in this patient that he was still hospitalized in the ICU after 5 months, still under mechanical ventilation, under vasopressors, and under CRT. And unfortunately, this patient actually died. We could not save him. What was very important in this clinical scenario is like this patient was very immunosuppressed. At the beginning of the hospitalization, we did an assessment of the monocytic HLA-DR, and as you can see, the level of immunosuppression was very high, only 2,000 antibodies per cell, which means that this patient was very, very immunosuppressed. All of us right now, we have, I think, for the expression of the HLA-DR at the surface of the monocytes, our antibodies per cell, it's about more than 15,000 antibodies per cell. Between 10,000 to 15,000 antibodies per cell, you have a light immunosuppression. Between 5,000 to 10,000, you have a moderate immunosuppression. And below 5,000, you are already very immunosuppressed. So this patient was extremely immunosuppressed. And that's why he couldn't fight against this sepsis during this hospitalization. So I think the key question we have here with hemoadsorption is like, would an early treatment with hemoadsorption applied within the first days post-ICU admission, be able to avoid these sepsis episodes, will allow us to reverse this immunosuppression and then save tons of money and keep the patient alive at the end of the ICU stay, which is, of course, the most important. So let's talk about a little bit about this immunoinflammatory host response in burns. But before that, let's come back to sepsis. You know, in sepsis, we have this reference to immunology in the definition of sepsis. Sepsis should be defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. So as you can see, in the definition of sepsis, you have this reference to immunology. And this is the host inflammatory response published by Richard Hotchkiss like 15 years ago. You have a double inflammatory response with a pro-inflammatory component and an anti-inflammatory component. And the net balance is more on the pro-inflammatory side during the first hours, and then it's on the anti-inflammatory side for the next days. And when the patient is under this anti-inflammatory immunosuppression state, the patient cannot fight against nosocomial infections, cannot fight against viral reactivations like CMV or HSV. And that's why we have such a high mortality rate at that moment of the sepsis time course. But this pathophysiology, this immunoinflammatory response, is it only in sepsis or is it in other clinical scenarios like burns, for example? Actually, this is what we studied in a large prospective observational study in my hospital, more than 500 patients. And we looked at the immunoinflammatory profile in all these clinical settings, in sepsis, but also in surgery, in trauma, and in burns. What we observed is like the immunoinflammatory response was very similar between all these clinical scenarios. So yes, the burn inflammatory response, the inflammatory response to burn is very similar to the sepsis. So burns is a sepsis-like syndrome when it comes to the host inflammatory response. We have hyperinflammation first and then a severe immunosuppression responsible for this secondary sepsis. And this is exactly what happened to this patient that I presented at the very beginning. He got a lot of secondary sepsis and he couldn't fight against this secondary sepsis. So I think immunology is now part of our job in the ICU, but it will be more and more and more part of our daily life in the ICU in the future. So when it comes to the treatment and the management of critically ill burn patients, of course, we have the cornerstones of severe burn patient management. You have a correct initial assessment of the burn injury, so it was 50% in this patient. We have a hemodynamic management with a lot of fluids to give to this patient at the very beginning, and then you have to organize the local treatment and the surgical treatment to these burn injuries. But still, when you do this very correctly, you still have a high mortality rate in these patients. So we need an adjuvant treatment that can modulate this inflammatory response, this immunosuppression state. Two possibilities, two ways to do this. First is immunostimulation, like in cancer. So you can give some immunostimulant, like IL-7, GM-CSF, or interferon gamma. And you have all these techniques, like these extracorporeal blood pressure techniques. Just one slide on immunostimulation. This is a case report on, again, a burn patient, a severe burn patients. And like our patient in the ICU, in our burn unit, this patient got also a severe infection. It was a mucormycosis, severe mucormycosis, a cutaneous mucormycosis. And this patient, the immunosuppression, the immune status was assessed also in this patient. The monocytic HLA was very low level of lymphocytes, and very low level of immature PMNs, which means that the patient was very much immunosuppressed. So this patient received interferon gamma. And then this interferon gamma boosted his immune system. And so after a few days of interferon gamma, as you can see on the slides here, you had an improvement of the skin lesions after interferon gamma. So the other way to modulate this inflammatory response is to give to this patient to provide EBP. So how does it exactly work? Because we have a very complex inflammatory response in burns. We still don't know so much, but of course the removal of all these cytokines is probably very interesting, because in burns the level of cytokines is extremely high. So what's the evidence in the literature of EBP in burn patients? Well, actually the literature is very poor. It was already very poor 10 years ago, in 2014, in this review, because only few publications, only few case reports actually with all the different blood purification techniques. So very little literature, very poor. Where this publication in pigs, in animal studies, it's 15 pigs, and there were 40% total body surface area deep burn. 9 pigs received hemoadsorption, and 6 received the standard treatment. And the pigs who received hemoadsorption received a 6-hour station for 3 days, day 1, day 2, and day 3. And then there were a lot of assessment, measurements of cytokines before and after the hemoadsorption device. The author found that the cytokine level decreased drastically after the filter. So the hemoadsorption cartridge, sorry, not the filter, the cartridge was able to remove from the blood some cytokines. But the cytokine level in the pigs did not change very much. Okay, so the cartridge was able to absorb cytokines, but the cytokine levels in the blood of these pigs remain quite similar, did not change. Another study in burns, this is not hemoadsorption, this is with high volume hemofiltration. This is a study from the US. It's a multicenter randomized controlled trial in burn centers. In this study, the patients received high volume hemofiltration, 70 ml per kilo per hour during 48 hours. Again, the cytokines did not change that much in the blood of these patients when they received high volume hemofiltration. But the positive result in this study is that there was an important hemodynamic improvement. The norepinephrine was reduced dramatically after high volume hemofiltration. So in this study, high volume hemofiltration was able to decrease the norepinephrine, so to improve the hemodynamic status. It was safe in these burn patients, but now we don't know about the mortality, of course, because not enough patients. Last publication I want to show in this presentation, it's a meta-analysis of blood purification therapies in burns. And first of all, the treatment was very safe. No adverse effects, no adverse events in this literature, in this publication. And there was a slight signal in favor of an increased survival. So like a very positive signal of an improvement of survival in these publications. So what's next in this clinical setting? We would like to start a project of hemoadsorption with the Jafron cartridge in severe burn patients. The study is currently being designed. We are working with the Jafron distributor in France. They have a new distributor in France this year, so we are working to implement this study in 3 French burn centers. We're going to randomize burn patients, and some of these patients will receive hemoadsorption with the Jafron technology, and some will not, so it will be the control group. The primary aim of this study will be to demonstrate that the Jafron adsorption device is able to remove from the blood cytokines. And also we're going to look, as I was talking about this before, we're going to look at some other immunologic parameters like the expression of HLA-DR on the monocytes. And we're going to look at clinical parameters as secondary objectives on hemodynamics, organ dysfunctions, and survival. To conclude, I would say that burns, it's a sepsis-like syndrome with complex pathophysiology. Hemoperfusion in burns, we have very limited data so far, but this is promising, I think, because of this high level of cytokines. So there is a strong rationale to deeply assess hemoadsorption in burns. Thank you very much.
Thank you very much.